Hi everyone, let's see about blood products. I'm Dr. Minu, ICU consultant, Neuro One Hospital. So first we have five different types of blood products, which is whole blood, packed red blood cells, platelets, fresh frozen plasma, and cryoprecipitate. So whole blood, as the name says, contains everything: RBC, plasma, platelet, clotting factors, and it's used when there is a massive blood loss. And nowadays they don't use it much because there is risk of volume overload. So it's not a must that you should always use whole blood, and it's rarely used whenever there is massive blood loss. So, when do you think we need to transfuse PRBCs? At what level of hemoglobin? Is it 7, 8, or 9? So, in a normal patient, a level of hemoglobin less than 7 is considered an indication for transfusing packed red blood cell, PRBC packed red blood cell. And if it's a post neurosurgery patient, we should maintain the hemoglobin level at least around a 9, which is a topic still in debate. But maintaining a hemoglobin of 9 is better. So if it's less than 9, you transfuse in a post neurosurgical patient, and in other normal patients less than 7, you transfuse. And if the patient has a cardiac disease like the EF is low, then we prefer a hemoglobin of 8. And when do you transfuse platelet? At what level do you transfuse platelet? You can easily do any surgeries even if the platelet is above 60,000. So 60,000 is the cutoff. Only below 60,000 surgeries are contraindicated, LSCS and any surgery. And platelets are mostly avoided if it's because of sepsis, thrombocytopenia because of sepsis, or immune induced thrombocytopenia, because whatever platelet you give is going to be lysed. And especially dengue fever is not an indication for transfusing platelet. We have seen many patients who have a platelet of 10,000, and just with IV fluid management and supportive care, the platelets which are stuck to the blood vessels will come into circulation again. So for dengue fever, no need any platelet transfusion. And what is the difference between single donor and random donor platelet? Single donor platelet is provides higher number of platelet compared to random donor, and it's not readily available. But random donor is readily available. The thing with single donor is lower risk of infection and immune reaction because it is from one person. But it's not indication that you should always give single donor platelet. The specific indication to give single donor platelet is a bone marrow transplant recipient patient, and the single donor platelets have longer shelf life. But random donor platelet is readily available, and that can safely be given for all our patients who need it. So, coming to the other blood components, we have FFP, cryo, platelets, plasma. So, what is FFP? Fresh frozen plasma. As the name says, it's kept in the freezer. And what are all the components of FFP? So, FFP and cryo, let's see what are all the components. Fresh frozen plasma is containing all the plasma in it, that is all the clotting factors 1 to 13. Whereas cryo contains only factor 8 and factor 13. and factor 1 is present in both. And cryo has von Willebrand factor, which is a factor which helps in platelet adhesion, whereas FFP contains albumin and immunoglobulin. So FFP basically contains all the clotting factors, whereas cryo contains 8 and 13. So when do you give FFP? So it's a 1:1 ratio. If there is a surgical blood loss of roughly more than 500 ml, then you give 1 PRBC with 1 FFP. If there is severe blood loss, you also give 1 platelet along with it. So the ratio is 1:1. 1 PRBC will increase the hemoglobin by 1 gram per deciliter. And when there is a blood loss, FFP will help, and you have to combine the PRBC with FFP. And it's also given when the patient has liver disease, cirrhosis, and coagulopathies. So cryo is rich in factor 8 and 13 von Willebrand factor as discussed. So whenever there is hypofibrinogenemia, like in massive transfusion, DIC, you can give cryo. So the fibrinogen level should be 2 to 4 grams per liter, but usually we don't check this as a usual practice in lab. So when there is a massive blood loss, you give 1:1:1. That is 1 PRBC with 1 FFP, 1 platelet, and then cryo is also given when there is a massive blood loss. So this is for post-trauma massive blood loss. And even if in surgeries, if the blood loss is more than 500, you give it in this ratio. So as we discussed, when the blood loss is more than 500, you give PRBC and FFP. And when the blood loss is post-surgery, when the blood loss is more than 1500, you give PRBC, FFP and platelet. So 500 is just 2. If it's more than 1500, you combine platelet along with it, and also cryo is given. And if life-threatening blood loss, which is more than 2500, then you follow massive transfusion protocol, and tranexamic acid helps to reduce the blood loss. So this RBC 1 unit containing 350 ml, that will vary according to your blood bank. So this is just a table differentiating between RBCs, FFP, cryo, which we already saw. And coming to the main thing, how long you should give, this is more clinically relevant, how long you should give and how you should give the blood products. So whole blood is given for 2 to 4 hours. PRBC is also given for 4 hours. Apart from blood, all the other components are given around 30 minutes. And for PRBC, if a person gives the PRBC from the lab, the staff should receive it in an ice pack, because it should directly be given to the patient from cold storage in order to avoid contamination and fevers. So PRBC should be given like that. And platelet is, they don't require freezing, they are stored in room temperature, and that's also transfused directly. So one main mistake they do is they don't receive it in ice packs and for PRBC before transfusing it to the patient. And platelet can be directly given, so that will not be a big mistake. Fresh frozen plasma, it's in the freezer, stored at minus 13 degrees Celsius, and it is thawed usually in the lab. So you should confirm it with your hospital. They thaw it in the lab for 30 minutes before giving it to you, and once thawed, it should be used within 24 hours. So they thaw it in the lab and they give it to you, so you can use directly, and you need to transfuse it for 30 minutes. Cryoprecipitate also is stored in the freezer minus 18 degrees Celsius, and it is thawed in the lab for 30 minutes, and once thawed you should use within 6 hours. So massive blood transfusion is if a patient comes to your emergency department with a road traffic accident, and if he is bleeding around 150 ml per hour, basically from the Ryle's tube, if it's 150 ml per minute, or post surgeries, if the blood loss, post neurosurgeries, or during surgery if the blood loss is around 150 ml per minute, or roughly 2.5 liter loss in 2 hours, then it's considered massive blood loss, considering the patient weight as 70 ml per kg. Then you follow massive transfusion protocol. So obviously, if it's in the emergency, you should call for help, assess the ABC, 2 wide bore cannulas, green Venflons should be inserted, and sent for routine sampling including PT-INR, and give warmed crystalloids, NS, and monitor BP. Most of the time you should monitor manual BP, check the pulse, and put a central line, arterial line for BP monitoring, and always measure the urine output. When the urine output is low, it means that the BP is low, and you give tranexamic acid 1 gram IV stat, which will reduce the blood loss, and then you can give 500 BD or even 1 gram over 8 hours. And you should look if the patient is on warfarin and consider reversal. And one important thing is about cell saver. Before that, when a person has massive blood loss, his heart rate will be more than 110, BP will be less than 90. You have to check it manually. Don't trust the monitors. Check the pulse and then check the BP. Urine output will be less than 20 ml per hour. So in that situation, you have to give 4 units of PRBC or 5 units of PRBC with 4 FFP. 1:1 ratio, but sometimes PRBC could be a 1 point above. And if it's trauma, give it with 1 platelet. So coming to the cell saver, we use cell savers in our hospital, and it has really helped in neurosurgeries in Neuro 1 hospital. So when the tumor is a highly vascular tumor, for example a pituitary macroadenoma, or any other vascular tumors, so cell saver, what it does is you use it when there is more than 1000 ml blood loss, and it will basically collect the blood from after the incision. Before starting procedure, when you give the incision, the patient will start bleeding. So the cell saver will collect the blood from there, and it will take it to the machine, and it will wash and remove the plasma, anticoagulants and everything, and it will just give the concentrated PRBC, and it will transfuse it back to the patient. The benefits are, it reduces the need for another person's blood, reduces the need, but still you have to give a little bit of blood from other people, and it's readily available, and it reduces infection and immunological reaction. So buying a cell saver and using it for patients in the surgery is worth it, and it really has saved many lives. And why do you only transfuse PRBCs back with the cell saver? As I told before, it washes all the plasma and the clotting factors and everything, because when you clean the platelets and clotting proteins, they may get damaged during suctioning. So that's why you don't transfuse those. The main purpose of using Cell Saver is to restore the oxygen carrying capacity. So that's by giving the PRBC. And the other factors like platelets and clotting factors are replaced separately. So for a patient, when you use a Cell Saver, the circuit and everything roughly would cost at 20,000 and the machine would cost 20 lakhs. But if it's a very busy surgical unit, then obviously this will really save lives, because it has reduced the death of patients on table because of bleeding, and it will also reduce the use of other people's blood and reduce immunological reactions, reduce infection, and so it's really helpful. Hope this was good and you learned something and it was not as it's shown here in this picture. Thank you.